We are happy to welcome you once again for today's Impact PG program. We are happy to once again connect in this week. Last week, we did take an intentional break because of critical care conference and most of the doctors were busy participating in Chennai. But we are happy to resume and I'm sure we'll be continuing to have it every Saturday at 7 p.m. Today, I'm happy to welcome Dr. Prem Prakrit. He's a consultant in Lizzie Medicity Hospital at Kochi. Thank you, Dr. Prem, for joining us today on this case discussion. I'm also happy to welcome Dr. Jyoti Reshma, who is also currently passed out student from Devi Memorial Hospital, Calicut. This will be the second time that she'll be participating in this program. So we are very happy to have you with us, ma'am, Dr. Jyoti. I'm sure today's discussion is going to really bring out a lot of quality thoughts for the students and help them take notes of it and make it useful for their future examinations. So with this, I hand over the session to Dr. Prem. Sir, can you take over from here?
Yes, sir. Thank you. So I'll start presenting the case, and in between we can have questions. Okay. Am I audible?
Yes, sir.
Okay. Okay. Fine. So.
Good evening, sir.
Yeah. Good evening. So. Next slide, please. Can you go to the next slide?
Yes, sir. Just a minute.
So here is a 54-year-old female who is a school teacher by occupation, who presents to the hospital with chief complaints of sudden onset severe headache since 2 hours, vomiting since 2 episodes, and loss of consciousness for last 20 minutes. Next slide. Next slide, please. Okay. So coming to the history of present illness, the patient was apparently well until 2 hours prior to admission, when she suddenly developed severe headache while watching television at home. The headache was sudden in onset, severe in intensity, maximum at onset, diffuse, and predominantly occipital. Next, please. Next, please.
Yes, I'm saying.
Okay, I have it with me. Okay, I'll read. So within minutes of having a headache, she developed 2 episodes of projectile vomiting and photophobia. And approximately 15 minutes after onset, she developed transient loss of consciousness lasting around 20 minutes. And family members noticed that she appeared confused. She complained of severe headache and she had difficulty opening her eyes due to light. There is no history of head trauma, fever, seizures, focal weakness, or slurring of speech. And she was brought to the emergency department within 1 hour of symptom onset. Next slide, please. So next slide. Past history. She's a hypertensive since last 10 years who is non-compliant to medications. There's no other significant past medical history. She was on amlodipine 5 mg once daily. That was also incompliant. So family history, there is a history of sudden death of father because of some intracranial bleed at the age of 62. And personal history, she's a non-smoker, no alcohol intake, and taking a mixed diet. So this is the short history. So can you move on to the next slide, please? So next slide, what are the possible differential diagnosis? Jyoti, if you can answer this question. What are the possible differences?
So this is a 54-year-old female So with a known case of hypertension on irregular medication, now presenting with symptoms
Some
of
issue with your audio. Can you just recheck? I think we are not able to hear it. Earlier it was good. Can you repeat your?
Hello.
No.
Hello, sir.
Yeah, now it's fine. Yeah.
Okay.
Please continue, sir.
So with this history and clinical, my first DD would be subarachnoid hemorrhage in ICH intracranial hemorrhage and migraine, very unlikely. Then hemiplegic migraine like that. Then also further down the differential, any intracranial space occupying lesion. Then hemorrhagic stroke. And no history of fever is there, but still I would like to consider meningitis also as a possibility, sir.
So why did you consider subarachnoid hemorrhage as your first differential diagnosis?
This patient, she is a female, 54-year-old female, known case of hypertension, which is a known case of risk, which is a non-modified risk factor. Then also family history of death in father, that is subsequently related. There is family history of some IC bleedings there.
Yes.
So, and also the characteristic of reached its maximum intensity within hours. That is characteristic of SA. So my first DD would be SAH in this patient.
Yes, yes, very good. So what is the character of headache in this patient? Is there any particular name for this character?
Yes, sir. Usually it is called thunderclap headache. That means the headache occurs with sudden onset and it reaches its maximum intensity within 1 minute, and sometimes it will last for about 5 minutes. That is the history.
Usually within seconds or at the onset, it reaches the maximum intensity. That's why it's called thunderclap headache. And why do you think that the headache, the severity of headache reach maximum intensity immediately? What is the reason?
It usually, this is due to the
So usually because there is a rupture of the aneurysm, the arterial blood enters the subarachnoid space suddenly. So that causes an abrupt meningeal irritation, one thing that can stimulate your meningeal nociceptors. And also there will be an associated rapid increase in the ICP. So these are the reasons why you get a maximum intensity at the onset of SH. Okay, that's why it is called thunderclap headache. Okay, so as you've noticed that this patient had projectile vomiting also. Why do you get projectile vomiting in this case?
Due to raised ICP, the dome of the aneurysm may be compressing the brainstem and other receptors. So
yes,
due to raised ICP, she will be getting projectile vomiting.
Okay. So due to raised ICP, your medullary vomiting center can get stimulated, which can cause projectile vomiting. Okay. So as you can see that there is a lapse in consciousness also. What could be the reason?
Yes. Probably due to the involvement of third nerve. Usually in PCOM aneurysm, the dome of aneurysm will be compressing the brainstem, thereby third nerve, abducent nerve will be compressed as a part of raised ICP. That would be the reason for loss of consciousness in this patient.
How can a third nerve compression cause loss of consciousness?
Sorry, sir. Sixth nerve palsy.
Okay, here third nerve or sixth nerve palsy is unlikely to cause a loss of consciousness. So your loss of consciousness in SAH is primarily because of your sudden increase in ICP, and also could be because of a transient global cerebral hypoperfusion, and also could be because of a seizure. So these are the reasons. If you have a third nerve or a sixth nerve compression, you may get a diplopia or you may get a deviation of, usually the symptom will be a diplopia, an abnormal eye position at rest. So it's unlikely to cause a loss of consciousness. Loss of consciousness results from a sudden increase in ICP or transient cerebral hypoperfusion or a seizure, usually in SAH. So in your differential diagnosis, I think you have mentioned that one of the D is migraine. Do you think that this could be a migraine?
There is no previous history of migraine, so it's very unlikely this could be
Yeah.
the first episode of the migraine.
So yeah, so at 54 years, it's very unlikely that she gets the first episode of migraine. And also, we don't usually see migraine with loss of consciousness like this. So even you can have this basilar migraine and all, which can be associated with the loss of consciousness, but still, it's lower down in the list. And I think you have mentioned about intracranial space occupying lesion also. Does it fit? Does the history fit into an ICSOL?
Usually, it will be a gradual presentation only, sir, not the
Yeah.
separate type of presentation.
Yeah. So this is a very hyperacute kind of presentation. So your ICSOL usually doesn't present like this unless if it is complicated by a bleeding into the space occupying lesion, or if there is an associated seizure. So otherwise, your history doesn't fit into an ICSOL. So according to me, your first DD should be a subarachnoid hemorrhage or an intracranial hemorrhage, a spontaneous ICH. Then followed by your other things. Could be a cerebral venous thrombosis also. It could be a reversible cerebral vasoconstriction syndrome, which is a close differential of SAH. Even though it's rare, that's also a possibility. And lower down in the list, you will have this migraine and even meningitis or acute ischemic stroke. All those things are the possibilities. Okay, so can we go to the next slide? Next slide.
Yes, and opulence.
Okay, coming on to the general examination. So patient is moderately built and nourished, drowsy but arousable, GCS of E2, V4, M6, pulse rate of 90 per minute, BP of 190, 100, SpO2 of 98% on room air. There is no pallor, icterus, cyanosis, clubbing, lymph node enlargement, or pedal edema. Next slide, please. So coming on to the neurological examination proper, higher mental functions, she was confused, irritable, and she was complaining of severe headache while examination. Cranial nerve examination was grossly normal. There was mild photophobia. Motor system, power was 5 by 5 in all limbs. Tone was normal and no focal deficit. And sensory system was normal. There were signs of meningeal irritations. So, what could be the next immediate management? So, you have examined the patient. After your history, your probable differential diagnosis is an SIH. What is the next immediate management?
So my priority would be to stabilize the ABCs, airway, breathing, and circulation. The patient is drowsy but arousable with a GCS of 12 approximately. And if she is able to talk and there is no symptoms of any risk factor for aspiration, we can consider the airway as patent, and breathing also spontaneous then well and good. Then next circulation part, her BP is about 190 by 100. In this phase, we don't know whether we are dealing with a bleed or a SH. So we would be ideally in SH the BP should be reduced to less than 160 as per the earlier guidelines. And one thing is there should not be sudden fluctuations in transmural pressure, which should be deleterious. So an IV
So
IV
what, in
bolus
short, what is the importance of BP in this patient?
The high BP may predispose to rebleeding. That is the major complication, dreadful complication we are expecting in this sever.
Yeah, so it should not be too high. It can cause rebleeding, and it should not be too low also. It reduces the cerebral perfusion. So that's why BP is important. So we'll come to that later. What is the importance of GCS in this patient in a case of suspected SAH?
GCS, the GCS is low at the time of admission. That indicates a poor prognostic factor because as per the grading of SH, as per Hunt and Hess, it will be coming under the grade. The GCS will be taken into the WFNS criteria. So that for prognosticating, GCS is important. Then for further management, intubation, and all also GCS is important.
Yes. So level of consciousness, basically the GCS correlates with severity and prognosis of SH. Okay. So as you have rightly mentioned, your World Federation of Neurosurgeons grading and the Hunt and Hess grading uses clinical neurological status for assessing or grading the severity of SH. So that's why your GCS is important in this case. So coming on to the immediate next management, we were discussing about the ABC approach, is it not? So airway, coming on
Yes.
to the airway, how do you assess the airway in this case?
Here the patient is having headache, but patient is drowsy and arousable with a GCS of approximately 12. So I will consider it as patent only, sir.
Okay.
And mm,
Okay.
then
So other than airway protection, is there any indication for you to intubate this case?
the patient, because we have to confirm the diagnosis by radiologically. So if the headache is so severe and it might can lead to fluctuations in ICP, so in that case we can consider prophylactic intubation and sedating as a tire approach to reduce ICP
So you
and to
mentioned that the
facilitate
GCS is,
investigation.
yeah. So you mentioned that the GCS is around 12 in this case. Is that
Yes,
a
sir.
high grade SH or a low grade SH? I mean the severity.
GCS is 12 without any motor deficit. That means it is a lower grade. That is means 1 or 2 grade.
Okay, according to which grade your WFNS?
WFNS grade. This is 12. So this is sorry, sir. Grade 4.
Yeah.
Grade
So
4.
see, irrespective of motor deficit, if your GCS is 12, it automatically becomes a grade 4,
Grade 4. Grade 4.
quite a higher grade of SH. So even if motor deficit is present or not, GCS of 12 indicates that the patient is having a higher grade of SH. So this patient is having a high grade SH, probably having a high ICP. So do you want to intubate? Uh, because just because ECS is 12 and he is able to protect the airway.
This is a high grade of SAH with raised ICP. So as a
Yeah,
prophylactic measure, we will intubate to reduce fluctuations in ICP
yeah, that also can be considered. Maybe we
and to
have to
facilitate
individualize.
investigation.
Yeah, yeah, definitely. So that's one possibility. Suppose if you want to intubate this patient, how do you want to proceed?
Okay. I would go with rapid sequence intubation, and
Okay.
I will pre-oxygenate with head up position, and after induction only I will keep the head in the flat position, and I will intubate rapidly, and along with that I will ensure adequate analgesia and sedation, and following intubation
Mm.
the patient should be brought to head up position immediately.
Okay. Any oxygenation targets you want to keep
Saturation
during
should be
induction?
more than 94.
Yes, yes. And what induction agent do you want to use in this case?
Propofol.
Yeah, you preferably want to use a short-acting agent uh, to uh, to
Yes, sir.
yeah, because you need to keep a minimum map to maintain your cerebral perfusion. At least a map of 75 to 80 is necessary because hypotension
Yes.
also is detrimental. So you can give a short-acting agent like a propofol or fentanyl while
Intermediate.
intubation, etomidate, And you should not hypoventilate the patient. That's also important, because any increase in
CO2.
CO2 can worsen your ICP. So these things has to be taken care while you are proceeding with intubation. Coming on to the breathing, what all you want to see? Breathing part. So once you have
Breathing.
intubated, yeah.
I will completely sedate the patient and I will put it assist control ventilation, and the breath will be titrated according to adequate ideal body, according to predicted body weight, and mode of ventilation, it could be volume control or pressure control or PRVC. Then
Okay.
completely sedate the patient. That is the main.
Okay. So main
Also,
in breathing,
my
you have to, yeah, you have to prevent hypoxia, avoid
hypoxia.
hypercapnia, and
Yes,
avoid
sir.
severe hypocapnia also. Avoid hypercapnia as well as severe hypocapnia, and
Yes,
maintain
sir.
prevent hypoxia. So that these are the things that you have to focus on. And while coming to circulation part,
Target.
yeah.
If the BP, we have to bring it down to less than 160 before securing the aneurysm. So a short-acting agent like labetalol will be preferred. An IV bolus of 10 mg can be tried, and MAP should be more than 95 at any
So
point of time.
before that, we need to confirm that the patient is
This
having an
is,
SH,
yeah,
right?
SH.
So
Yes, sir.
for while intubating, what you can do is that you should have an aggressive BP monitoring. Avoid extreme hypertension and hypotension, because you don't know whether it's an SH or not till now. And avoid fluctuations in systolic BP that is associated with the rebleeding if it is SH. So these things has to be taken care of while you're assessing and stabilizing your circulation part. You can place a 2 large bore IV cannula, continuously monitor BP, avoid extreme hypertension and hypotension, and avoid fluctuations, because uh, 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 huge transmural pressure across the aneurysm can cause rebleeding. Okay, that's one thing. So once you have stabilized your airway, breathing and circulation part, what do you want to do next?
I would like to investigate simultaneously. I will go with non-contrast CT head
Yeah.
first.
Okay. So
And if
next step is to do a non-contrast CT. Okay. So that's your investigation of choice to confirm your diagnosis. So what do you want to do if your a non-contrast CT brain is showing an SH?
NCCT suggestive of SH, then I will proceed with DSA after discussing with the family, because DSA is the gold standard modality for diagnosis and treatment of SH, because we can see what type of aneurysm is that and whether it is amenable to endovascular therapy or not. So it has got both diagnostic and therapeutic advantages. So I will proceed with DSA.
What about CT angiography? You don't want to
CT
do a CT
angiography.
angio?
Yes, sir. CT angiography also can be done, and we can find out the site of lesion. But the thing is, aneurysms less than 3 millimeters will be very difficult to pick it out in the CT angiograph.
Okay. See, but what if it is a non-aneurysmal SH? So the thing is, if you are having an SAH in NCCT brain, the second step is to automatically go in for a CT angio, because obviously DSA is a gold standard, but you will have to mobilize your patient to a cath lab or whatever it may be. You can identify location, size, and all, but it is preferable to go for a DSA if CT angio fails to pick up an aneurysm. So that's when you straight away like prefer a DSA. Otherwise, your CT angio itself will be enough to pick up an aneurysm. So that is one thing. So can you move to the next slide, please? Next slide. How common is aneurysmal SH?
Aneurysmal SH accounts for about 85% of uh, spontaneous SAH.
Uh.
15% would be perimesencephalic and other thing. Then 5% will be related to connective tissue disorders and Ehlers-Danlos, neurofibromatosis, moya, etc.
Okay, okay. So, so next slide, please. Next slide. Coming on. Next slide. Next slide. Next. 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 So next. So I told. So suppose if the initial CT fails to pick up an SH, is there any other option to diagnose SH?
The guidelines say if the initial CT is normal, then we can go for lumbar puncture after 6 to 12 hours. We can look for xanthochromia by looking at the supernatant fluid showing xanthochromia in first 4 bottles.
Yeah, so it should be after at least 6 hours. At least 6 hours after having an SH, your CSF can have xanthochromia. That's one of the method by which you can diagnose an SH. So if initial CT fails to pick up an SH, you know that it's not a high grade SH. So you have time. After 6 hours, you can do an LP and look for a xanthochromia. Okay. So next slide, please. Next slide. So these are the causes of SIH, aneurysmal up to 85%. The others are the non-aneurysmal causes of SIH, like trauma, tumor, infection, inflammation, drugs, etc. Or vasculitis. All these are causes of non-traumatic, non-aneurysmal SIH. Next slide, please. So incidence is around 2 to 22 per 1 lakh population, the age of around 40 to 60 years. There are sex as well as racial differences in incidence. Next slide, please. So there are certain risk factors associated with an aneurysmal SH, like hypertension, smoking, alcohol, and there are some genetic factors, genetic diseases where you can have aneurysm, predisposition for aneurysms, like ADPKD or Ehlers-Danlos syndrome, all those things. No, next slide, please. Okay, so these are the common sites of having an aneurysm: your anterior communicating artery and posterior communicating artery and MCA. These are the sites where you have maximum incidence of having an intracranial aneurysm, followed by your ICA bifurcation, basilar artery tip, and pica. So these are the important locations where you find your aneurysms. Okay, next slide, please. Next slide. So as you've already mentioned, these are the severity gradings. This is your World Federation of Neurosurgery's grading of severity of SAH. As we have already mentioned, this patient is having a GCS of 12, and irrespective of having a motor deficit, your grade is automatically grade 4, which is a high grade SAH. Okay. So next slide. And this next slide, please. This is your modified Fisher grading. That also this is a CT based grading. So you can see that this is an image of a CT brain. What is there in the CT brain? You can identify.
This is showing that star sign where the cisterns are infiltrated.
Yes. So you can see that there is a hyperdensity in the supracellular and the interpedunculair cisterns, which is called as the star sign, which is seen in an acute SAH. Okay. Next slide, please. Next slide. Okay. So what is the immediate treatment goal in the ICU?
BP reduction to less than usually our goals of therapy can be classified into 4. First, initial stabilization. Second, treatment of the aneurysm. third, prevention of complications and secondary brain injury, and fourth is general ICU care. All these things should go simultaneously. So we
Yeah.
have stabilized the patient. So next we have to take up the patient for procedure,
Yeah.
whether it is
Okay.
endovascular or surgical,
Okay.
to prevent
Yeah.
rebleed, that too within 24 hours.
So yeah. So our immediate within 24 hours, the chance of rebleeding is very high, and you know that if the patient rebleeds, the mortality is also going to be very high. So our immediate goal in the first 24 hours in the ICU is mainly preventing the rebleed, which includes your BP control, securing the aneurysm, and your antifibrinolytic therapies. We are doing all these measures just because we don't want the patient to rebleed. So coming on to BP control in SAH, do you want to tell how do you want to control BP in this patient?
Um, Before securing the aneurysm, I would
Yeah.
like to target the BP to less than 110. Oh, sorry, sir, 160. Uh, and MAP should be at any point should be more than 65 to 95, that range. So I will be using a short-acting titratable antihypertensive like labetalol.
Okay. Okay. So this do you have a target BP reduction goal for acute SAH before securing aneurysm?
There is no target given as such as per the 2023 AHA
Yeah.
guideline.
So in previous guidelines, they used to have all these targets, like as you have said already, 160. So reducing the BP to at least less than 160 was recommended. So that was one thing which was there previously, but as per the new recommendations by your Neurocritical Care Society 2023 guidelines, and as per your AHA guidelines, so there is no evidence to recommend a BP reduction goal for treatment of hypertension before securing the aneurysm in acute SAH. And also, AHA recommends that in patients with acute SAH with an unsecured aneurysm, what you can do is you monitor BP frequently and control BP with the short acting medications. So your main goal is to avoid hypotension and severe hypertension and BP variability. So that's your goal. That's clearly mentioned in your AHA, but they have not mentioned a clear BP reduction goal, especially before tackling the aneurysm. So suppose if you want to control BP, which drug you want to use?
Like, nimodipine can be given.
Yeah.
Labetalol, IV labetalol 10 to 20 mg, bolus followed by infusion.
Yeah, so easily titratable drug. So we have to use an easily titratable drug. So especially your labetalol, esmolol, and all can be used as options to control your blood pressure. Suppose if this patient, suppose I'll give you a case scenario. Suppose if the BP is 200 100 in a patient with SH, how do you want to proceed?
Rapid reduction of BP is also detrimental because any fluctuation in transmural pressure can itself lead to rebleed. So I would like to reduce it gradually, like to 25% reduction in the first hour, and assess for the GCS, and like that I will reduce the BPs.
Okay, so I'll just explain this to you. Suppose if you have a patient with a BP of around 200, suppose 200, 100, and patient is having acute SAH, and your initial BP reduction depends on the severity of SAH. That's what. So there are few things that we have to consider in this in reducing BP in these kind of patients. So you see whether it's a severe grade SH or a good grade SH. So yes, for example, if the Huntington has grade is less than 3, or or the WFNS grade is less than 3, or a Fisher grade of less than 3, suppose. So those are good grade SAH. So in such patient, you know that if patient is presenting early, that is within some 24 hours of having an SAH, suppose if patient presents to you, you know that the patient is having a good grade SAH, you know that the ICP is not going to be very high, and you are not worried about vasospasm in these patients, because patient has presented to you early. So in this cohort of patients, I think you can have an aggressive reduction in BP. Maybe you can reduce to 140 or 130. So because you have a good grade SH, and you don't have a worry about vasospasm, you know that the ICP is not too high, you can have a BP reduction. Okay, suppose if this patient with a severe SH, for example, your Fisher grade more than 3 or WFNS more than 3, who is good grade SAH, suppose if he's presenting late, for example, after 4 days, so you know that ICP is not very high because your SAH is good grade, but now you're worried more about your vasospasm and the delayed cerebral ischemia. In such cases, you know that the rupture risk is not very high because it's already 4th day, and in these patients the period of vasospasm has already started, so the risk of re-rupture also has reduced. So in these patients you can keep a BP a little higher, no need of aggressive reduction in BP. Okay, hope you are understanding.
Yes, sir.
Understood. If it's a good grade SH, if it's a good grade SH, you see whether the patient has come early to you, or whether the patient has come late to you, whether your concern is maintaining the cerebral perfusion, or whether your concern is a risk of re-rupture. Your management or your BP reduction base will be dependent on all these. Suppose if it's a bad grade SH, suppose if it's a severe SH of like a Fisher of more than 3 or WFNS of more than 3 or 4, you know that your patient is having a very high ICP. And suppose if the patient is having a BP of 220 or 230 or 240, uh, your uh, your uh, your patient may be maintaining the cerebral perfusion pressure with this high BP. Okay, because ICP is already high, you need this much of BP to maintain cerebral perfusion pressure, and any aggressive reduction in BP is going to worsen the cerebral perfusion. Okay, especially after 4th day, especially after a period of vasospasm has started, you don't want. So if it's early, bad grade SAH presenting to you very early, you can reduce, but no aggressive reduction. Especially you should prevent hypotension somehow. If if the patient is presenting late, you have to be even more careful while reducing the BP. Okay, in those cases, maybe you may have to put an ICD, EVD, and
EVD.
EVD and measure the ICP, and then you can reduce the BP by keeping your cerebral perfusion pressure in the target range. So that should be your approach while uh, uh, tackling or while controlling BP in such a case. Okay, so this case is a severe SAH with a WFNS grade of 4, and she has presented to you early. Do you want to do an aggressive BP reduction in this case? BP is too high.
Aggressive reduction is harmful in this case because already ICP is raised.
Yeah. So already, because it's a severe SAH, your ICP is going to be high, and to maintain the cerebral perfusion, your MAP has to go up. That's why your BP is high. So if you are reducing BP aggressively in these kind of patients, your cerebral perfusion pressure
Perfusion
is
pressure.
going to it's going to come down, and you're going to worsen the cerebral perfusion. So you have to be very careful while reducing BP in these kind of patients. Maybe you need an aggressive ICP monitoring. Maybe you can have an EVD in place. You can transduce the EVD and measure the ICP, and you can gradually reduce the BP by maintaining your cerebral perfusion pressure in target range. So that should be your answer. Okay. So coming on to ICP management. So can we move on to the next slide? So to prevent, next please. So to prevent rebleed, first BP control, second securing the aneurysm, and third antifibrinolytic therapies. These are the options that we have. Next slide please. BP control in acute SAH we have already discussed. Okay, how do you want to go with controlling the BPs? So regarding securing the aneurysm, so that also is very important to prevent rebleed. So you have two options, coiling and clipping. So in this patient, how do you want to proceed?
This is a 54-year-old female. So the patient is having grade 4 SAH, and I would proceed with DSA to see where the aneurysm is. And depending upon the site of the aneurysm, I will proceed further. And based on the ISAT and BRAD trials, endovascular coiling has got disease-free interval compared to surgical clipping, though functional outcome after 10 years remains same with both clipping and coiling.
Okay. Yes. So very good. So in general, can you compare coiling and clipping?
Yes, sir. Coiling we will be doing in posterior fossa lesions and in patients with age more than 70 years with salvageable features. And clipping, if the neck of the aneurysm is wide or broad, more than 4 mm, and MCA, then in younger patients, that is age less than 40, who have a longer duration of lifespan, and so there will be less recurrence of rebleed, because the issue with coiling is it has got a propensity to rebleed.
Okay. Okay. So which trial compared clipping and coiling?
ISAT trial and BRAD trial.
Okay. So you can go back and read the details of these trials. So moving on, next slide, please. Next slide. Okay, so the slides just shows the clipping and coiling. What you're seeing on the left side is the clipping, and you can see coiling, which has been done for an aneurysm on the right side. Okay, so next slide, please. Next slide. So coming on to management of ICP. So what are the indications for ICP monitoring in this age?
The indications for ICP monitoring in SH includes GCS less than or equal to 8, then acute hydrocephalus, then cerebral edema, and to facilitate drainage of the hydrocephalus, CSF.
Yeah. Okay, if there's a progressive worsening of clinical status, and automatically if there is a higher grade of SH, you to have a better control of your ICP, your cerebral perfusion and all, and to titrate further therapy, you need to have a ICP monitoring device in place. So uh, can you tell me in brief about the different tiers of management of ICP?
Tier-wise management of ICP includes Tier 0 to Tier 3. Tier 0 includes general measures like adequate sedation and analgesia, so that the patient doesn't fight with the ventilator, and then proper position, head and elevation to 30-degree, and maintaining normoxia, normocryobia, normoglycemia, and prevention of fever. And then Tier 1 includes sedation so as to reduce the ICP. Then we can consider an infusion of fentanyl or propofol. And our aim is to maintain a cerebral perfusion pressure at the range of 60 to 70. And here we can add hyperosmolar therapy, either a 3% saline or a mannitol. And if the grade is high, we can consider putting EVD also. And GCS is less, we can consider ICP monitoring. Then grade 2
Okay.
includes neuromuscular blockade, and grade 3 includes rescue measures like decompression and barbiturate coma, hypothermia.
Okay. Okay. So in tier 2, do you want to add anything?
Tier 2, neuromuscular blockade, then MAP challenge can be given.
So what is a
to
MAP
see
challenge? Yeah.
to see whether auto-regulation is intact. So here, what we do is we will give a pressure and to see with more than 10 mm rise in MAP, the ICP is reducing or not. If the autoregulation is intact, ICP will automatically come down. If the ICP is increasing, that means autoregulation has lost.
Yeah. So if a patient is having a particular BP, and if you want to know whether this BP is enough for that patient, suppose you have given your tier 1 measures, you have given osmotherapy, you have given other basic whatever is required to reduce ICP, but still you have a very high ICP, you want to come down, you have to reduce the ICP further. One option is giving a neuromuscular blockade and doing a MAP challenge. Okay, so ideally you need to have an EVD in place, and you need to have a continuous invasive ICP monitor to see whether your intervention has reduced your ICP. So ideally, if your autoregulation is intact, what is going to happen when you augment the MAP, when you increase the MAP, your vessels should vasoconstrict, and your ICP should, your blood volume should come down, and your ICP should come down. So which tells you that your cerebral autoregulation is intact. Okay, so in those subgroup of patients, you can have a you can do a MAP augmentation. You can transiently increase your MAP. So how are you going to increase your MAP to do a MAP challenge?
By using a vasopressors like noradrenaline, and we have to keep MAP of 10 mm for about 20 minutes and see whether the ICP is getting lower or not.
Yeah. So if auto-regulation is not intact, when you go upon your MAP, your ICP is going to increase. So ideally, you need to have a continuous
ICP monitoring
invasive,
device.
ICP monitoring device is needed. If you don't have an ICP monitoring device, what do you want to do?
We can go with TCD monitoring or continuous EEG monitoring.
Yeah, okay. So at least you can have a TCD in place, and you can see the pulsatility index, whether it is increasing or reducing, to see the ICP. Okay, so that is about MAP challenge. That's also important in managing these cases. Okay, so next slide, please. Next slide. So after clipping, what is your next concern? You have done a clipping for this patient, and the patient has come back to the ICU. What do you want to do? So what is so the after clipping, what has changed here? Is there any change in goals of care?
So we have secured the aneurysm. So
Yes.
our next concern will be to prevent the secondary injuries, and also the proper neurocritical care comes to the place in this stage. And
Yes.
here our BP goals will also change. Here we can allow a permissive hypertension, and euvolemia should be ensured, and also in later stages vasospasm can occur, so we will start nimodipine 60 mg q4th hourly, and it should be continued for 21 days. And along with that, general ICU measures like feeding, analgesia, sedation, thromboprophylaxis, ulcer prophylaxis.
Okay. So after clipping or coiling or whatever it may be, your chance of rebleeding is very less after that. Okay. So now what change you have to make in your management so as to prevent this secondary brain injuries?
At any point of time, we should maintain euvolemia, provided the patient is having good cardiac function, and then BP.
So you
We
now,
can.
yeah, you have to focus on maintaining a adequate cerebral perfusion so that your secondary brain injuries like your delayed cerebral ischemia and all those things are minimal. So that's your change in goal of care. So suppose going on to the next slide, please. Next slide. Next slide. So day 4 in the ICU, suppose patient develops a right upper limb weakness. How do you want to approach?
Right upper limb weakness. So for neurological deficit has there. So I would repeat the imaging to look for any features of DCA, like any infarcts are there, which is not attributable as a part of the intervention. And also along with that, I will ensure anomoxia and the electrolytes are within normal level, especially sodium and magnesium. Then also GRD is also normoglycemic.
Okay. So, suppose if patient develops the new onset of weakness of the right upper limb, you know that one possibility is a delayed cerebral ischemia. Once you have ruled out the other important causes like metabolic or seizures, all those things you have ruled out, and you know that this could be a vasospasm causing DCI. So, how do you suspect DCI?
DCA, it could be focal or global deficit. That is a drop in GCS of more than 2 points, sustaining for about 1 hour, which is not attributable as a part of the complication of the procedure, and which is not explained by other causes also. Then we can say the patient is having DCA.
Yeah, so there should be a new focal neurological deficit, or there should be a drop in GCS by 2 points. Okay, so which should be there, which should be persisting for at least 1 hour, and no other attributable cause, and usually after your aneurysm occlusion. Your aneurysm has been, so you can do a CT or an MRI to see whether there is any rebleeding. So once everything is ruled out, could be a delayed cerebral ischemia. So what is the difference between vasospasm and DCI?
DCA is an umbrella term. Vasospasm is one of the factors leading to DCA. DCA, it could be due to vasospasm, cortical depolarization, microthrombi formation, and other systemic inflammation syndrome. And vasospasm is one of the factors contributing to DCA.
Yeah, so vasospasm is only one of the factors that lead to DCA. There are many other reasons for DCA. So simply vasospasm doesn't mean that patient has developed a DCA. Okay, vasospasm will be present case of SIH, but DCI recognized vasospasm. Okay, so vasospasm is only one of the cause of delayed cerebral ischemia. So how do you diagnose DCI? So you have suspected a DCI because there is a new focal deficit or GCS drop or whatever it may be, which is persistent for last 1 hour. You are suspecting a DCA. How do you want to diagnose it?
I will repeat the imaging
Yes.
if it is feasible, CT angiogram, and I will also look for the monitor TCD and see the mean flow velocities.
Yeah. So once you have suspected DCI based on your clinical neuromonitoring, the next thing what you want to do is you do a baseline bedside TCD and radiographic investigations like a CT angio or an MRI or a DSA. So, okay, so that should be your approach. So how is TCD important in managing these patients if you are suspecting a delayed vasospasm and DCA?
Post securing the aneurysm, ideally we should monitor a mean flow velocity of the involved artery at least once daily, and the mean flow velocity, if it is less than 120, that is normal. And if it is more than 120, we have to look at the Lingard ratio, which is the ratio between MCA and ipsilateral extracranial part of ICA, because the mean flow velocity can be increased by two conditions. Either there will be increase in blood volume, or it will be due to constriction of the vessel. To rule out that, you have to see the Lingard ratio, and the Lingard ratio is less than 3. That means it is due to hyperemia, and if it is more than 3 to it's between more than 3 to 6, that means mild to moderate vasospasm, and if it is more than 6, that means severe vasospasm.
Yeah. So basically, your TCD assessing by using a TCD, assessing your mean your middle cerebral values, velocity values also, but this is the only validated MCA of more than 200 with a Lindegard ratio of more than 6 having a severe vasospasm. So what is the cutoff? It is 120. So if it is more than 120, you see the Lindegard ratio, whether it's less than 3 or more than 3. Okay. If it is more than 200 and Lindegard ratio more than 6, you know that your patient is having a severe vasospasm. Okay. So anything about ACA territory vasospasm using TCD?
ACA territory.
Is there any cutoff?
Posterior circulation, there is something called Srivi index, and
Yeah.
territory, I'm not sure.
Regarding your with regard to your mean flow velocity, there can be a probable, possible, or definite vasospasm. In MCA territory vasospasm, you have mild, moderate, and severe. Not like that. Your ACA territory vasospasm, there is probable, possible, and definitive vasospasm based on the mean flow velocity. So if its mean flow velocity is if it is more than 80, then it is possible probable vasospasm. If it's more than 100, it's possible. And if it's more than 120 or 130, it is definite vasospasm. Okay. So PCA, this is ACA values, anterior cerebral artery. And for PCA also, any values, mean flow velocity values more than 100. If it's a 3-digit value, there is vasospasm. Okay. But the only validated parameter is your MCA mean flow velocity value. Okay. So that's about your TCD. Coming on to your pulsatility index in TCD. What do you know about pulsatility index in TCD? How it helps in managing SAH patients?
Pulsatility index, it will be raised in cases of vasospasm, and if the augmentation, augmentation can bring down the pulsatility index. That means math challenge.
Yes. So pulsatility index denotes your distal resistance, your resistance at the level of your capillaries or the arterioles. Okay. So it's an indicative of an increase. A higher pulsatility index indicates that there is a high distal resistance, while your high main flow velocities indicates that there is a spasm, or there is a vessel narrowing at the place of insunation. Wherever you are measuring the mean flow velocity, at that place there is a narrowing and the velocities are high. But if your pulsatility index, if it is high, you know that it's a measure of your distal resistance. So whatever is happening at the level of your arterioles. If your PI is high, you know that your distal resistance is high. Okay, could be because of a high ICP. That's why PI is a surrogate of your ICP. If PI is high, your ICP is high. Okay, fine. So next slide, please. Next slide. So, so diagnosing DCI, we've already mentioned about TCD. And coming on to the radiographic options, you have your CT, MRI, and all. What is the role of CT angio or an MRI or DSA in diagnosing delayed cerebral ischemia?
The patient is having an acute worsening of sensorium post procedure. We have to rule out bleed also. So in that case, CT is less time consuming, and by CT angiogram we can see whether the rebleed is there or any new infarct has come up, and or whether any new aneurysm has ruptured. So in that way, CT angio is useful.
Yes. So, so one thing is it can rule out a rebleed. That is one thing. Second, it has got a very high sensitivity for central angiographic vasospasm. Okay, but it's very poor marker for a distal
Distal.
vasospasm at the level of your arterioles. So it has got a very good sensitivity for a central large vessel angiographic vasospasm. You have certain CT angio vasospasm scores which are direct predictors of your delayed cerebral ischemia and your poor neurological outcomes. So it's about CT angio. Is there anything else which you can do with you can get with CT? Is there any other option? So there especially to detect what is happening at the level of your microcirculation, because your CT angio picks up only a large vessel vasospasm
Yes.
or a central
CT
vasospasm.
perfusion.
Yeah, so that's CT perfusion imaging, which can detect alterations in microcirculation in addition to the macroscopic vasospasm. So which can be detected with CT angio. So CT perfusion is also one of the option to detect, especially your micro circulation level vasospasm. Macro in addition to your macroscopic vasospasm. Okay, that's about CT angio and CT perfusion. Anything about DSA?
DSA, I'm not sure, sir.
Okay, DSA is the gold standard to diagnose cerebral vasospasm. Okay, if you are still suspecting that the patient is having vasospasm, you are unable to pick up a DCI with your MRI or CT angio, CT perfusion, you can always do a DSA to see whether there is any angiographic whether there is any cerebral vasospasm. Okay, so that's about diagnosing DCI. Uh, uh, can you tell me the role of EEG in diagnosing DCI?
Continuous EEG monitoring is essential. Here we can look at the velocity of the alpha waves and delta wave, and
Yeah.
in higher grades of hemorrhage and vasospasm, there will be slowing of alpha waves and there will be reduction in the ratio of alpha to delta.
Yeah, so there can be a reduction in alpha delta ratio, and there can be epileptiform discharges. All those are predictive of DCI. What is the disadvantage in using the EEG?
Uh,
You need an
Continuous
expert.
EEG monitoring,
You
yes.
need an expert. That is the thing. You need an expert to carefully analyze the EEG patterns and to tell you that there is an ongoing DCI. So that's the only disadvantage. Okay. So coming on to the next slide. Next slide. Next. Treatment of vasospasm or DCI. Next, please. Yes. So, how do you treat vasospasm or DCI?
Once the vasospasm has occurred, then our goal should be hemodynamic augmentation of the MAP, and we have to raise the SPP to more than 200. There is no definite cutoff given anywhere, and here we can consider using a vasopressor like norepinephrine or phenylephrine. And
More
if the
important
clinical
than hemodynamic augmentation, anything else you want to?
maintain euvolemia.
before that? Yeah.
Nimodipine.
Yes. So nimodipine is the only pharmacological intervention so associated with a better outcome. No, so you have to use nimodipine. Okay, so which has got outcome benefit in patients with SAH. Even though we are using it, it has got no effect on large vessel vasospasm. Okay, it has got action at the level of your arterioles, and there is no much benefit on large vessel vasospasm. Okay, so nimodipine has to be used. So what is the recommended dose? How do you want to start nimodipine?
Recommended dose is 60 mg per orally or through nasogastric tube, and 4th hourly, and it should be continued for 21 days. And if there is any occurrence of hypotension, we have to half the dose.
Yeah, okay. So even higher doses are also described, but this is the only concern. If the patient develops hypotension, you may have to reduce the dose. You can make it half. That's also possible. So there is a demonstrated benefit in the form of reduction in cerebral infarction and reduction in poor neurological outcome and even death with oral nimodipine. So there is no much evidence for your IV nimodipine. In fact, it is associated with much worsening hemodynamic profile, and that even can cause worsening of cerebral perfusion and worsen the cerebral ischemia. So oral nimodipine is a preferred choice for your delayed cerebral ischemia. So what are the other methods by which you can treat DCI?
Earlier concept was the triple H therapy, which was hemodilution, hypovolemia, hypertension, which is no longer recommended. We can, at any point of time, we have to maintain euvolemia, and augmented hypertension that we can give. And then even if the BP is
practical exam
किसने बोला है?
Hello.
कर दें इंट्यूबेट?
Hello.
Sir, am I audible?
Yes. Please continue. Yeah.
So as we were telling, even if after maintaining the target BP for more than 1 hour, the symptoms has not been resolved, then we have to consider other methods like angiography or intra-arterial vasodilators like nimodipine, papaverine, nicardipine.
Okay, fine. So how do you want to, has it got any clear outcome benefit in respect to, with respect to the mortality or functional outcomes for this induced hypertension or hemodynamic augmentation?
No, sir. Only nimodipine has been that is a cerebral vasodilator that has the only proven benefit.
So you can try using this induced hypertension or hemodynamic augmentation in order to increase your systolic blood pressures and to optimize your cerebral blood flow and to prevent the DCI. But despite having this positive neurological outcomes, there is no much evidence to recommend induced hypertension in acute SAH. Maybe because of possible complications such as your pulmonary edema or myocardial ischemia, and even it can cause a rupture of other aneurysms which are not secured. So these are the possible risks while using this augmented hemodynamic augmentation or induced hypertension. Okay, so now if you want to give a trial of induced hypertension, what do you want to use? Which agent do you want to use?
We can use norepinephrine or phenylephrine, and if the LV function is reduced, we can go for a trial of anodilators like milrinone.
Okay, okay. So better to use noradrenaline. That is the most commonly used drug. You can use phenylephrine also. And what a target do you want to keep?
SBP should be raised to a target of more than 200 to 220. In some
Okay.
studies, it's telling like 220 is beneficial, but as per AHA has not recommended any specific cutoff for the same.
Yeah, yeah. So you can, it's actually you have to individualize. You can use your tests for seeing whether your cerebral autoregulation is intact, and you can individualize the BP so that your ICP should be less. At the same time, your chances of cerebral hypoperfusion is also less. Chances of rebleeding should be less. So these are the things that which you have to consider when you are doing this induced hypertension. At the same time, you should be cautious about your myocardial ischemia or pulmonary edema and re-rupture of other aneurysms also. So these are the things that you have to consider. So mostly, yeah, the target of 220 for SBP or usually 140 for MAP, and 110 to 120 for CPP has been described. Okay, and a stable neurological condition for at least 24 hours has to be obtained, and then you have to slowly de-escalate in a stepwise fashion. So that's what is recommended, but there are no guidelines for de-escalation also. Is there any role of using advanced hemodynamic monitors like a PICO or a LITCO or a pulmonary artery catheter in
It
cardiac
can be
output
used.
documentation?
It
Yes.
can be used in guiding fluid therapy. To know the hemodynamics,
Hmm. Okay.
especially
Yes.
if the patient is
It can.
intubated, we can see at the pulse volume variation.
Yes. Pulse pressure variation, even simple
Sorry.
parameters like your pulse pressure variation, or doing a PLR, all those things can be used. If you have the luxury of having a PICO or a LITCO, you can use that also. But there are no clear-cut recommendations for this. You can use. That's all. Okay. And what about volume status? Do you prefer hypovolemia or
Euvolemia, sir.
euvolemia? Okay. Earlier there was a recommendation that you prefer
Hypervolemia.
hypervolemia, so that, yeah, so that your blood volume is high, your cerebral perfusion is also high. But there are complications for that also, in the form of developing pulmonary edema and all those things. So now at any point of time, you should have euvolemia, which should be maintained throughout. Okay. So, and while giving fluids, you can always use these parameters like your pulse pressure variation or something like that. A little more advanced invasive monitoring can be used while considering giving fluids. That's all. The thing is, after aneurysm has been secured and once day 3 or day 4 has passed, you start giving them fluids, is it not? To prevent delayed cerebral ischemia. But we have to be careful because you should not overload the patient with fluids because of all these complications. Maybe you can keep a target of around like positive balance of around 300 to 500 daily, so that insensible losses are also covered, and maybe your patient is in a state of hypervolemia. I mean, sorry, euvolemia. Along with that, you can always assess flow for fluid responsiveness and fluid tolerance before giving fluids every time. Okay, so that is a practical way of approaching this. Okay, what is the role of milrinone?
Milrinone, if cardiac index is less than 4.1, and if the LV ejection fraction is less than 40, we can give milrinone also.
Okay, so suppose if you have done all these, you have started nimodipine at the correct time, you have done hemodynamic augmentation, you have maintained euvolemia, Despite that, the patient is worsening. So what could be the next option?
Balloon angioplasty.
Okay, before that, any endovascular procedures you want to do? You can uh, do an intra-arterial injection, right, of
Administration of nimodipine or nicardipine.
nimodipine or nicardipine or milrinone, or those things can be tried if there is a worsening of neurological function. And if there is, you are suspecting that there is a worsening of delayed cerebral ischemia or persistent vasospasm, you can try all these. Okay. Now, what are the other? This thing is also an option, like percutaneous an angioplasty of the narrowed vessels. Okay, that's also an option for refractory vasospasm, especially if there is a large vessel vasospasm. If it's at the level of small vessels, even that may not be beneficial. Okay. So next slide, please. Next slide. Next slide. Next slide. Next slide. Yeah. So how do you manage these complications? What is this in the CT?
This is showing enlargement of the ventricle, probably due to hydrocephalus. Hydrocephalus in SH can be due to either the blood occluding the foramen or as a part of the loss of resorption properties of the subarachnoid granules. So, with the we can put an EVD.
Yeah. So what is the incidence of hydrocephalus in patients with SH?
15 to 20%.
Okay, can be as high as even 50 to 60%. Okay, and if a patient with a SAH is having hydrocephalus, when do you want to intervene?
We can consider putting an EVD in place because the hydrocephalus itself will give an erroneous grading of the staging of the condition. So after putting EVD and draining the hydrocephalus, we can go for the repeat imaging and grade the condition accordingly.
Yeah. So if there is an associated hydrocephalus, that itself can worsen your consciousness. So you may not be able to properly monitor the GCS in those patients, especially if they have an acute SAH. So especially if they are in a phase of vasospasm, any worsening GCS, you are more worried of vasospasm and DCI. So your associated presence of hydrocephalus can affect your judgment, right? Your GCS may not be correct. So you can have an EVD in place in such patients when there is associated decreased level of consciousness. And EVD can facilitate CSF drainage and ICP monitoring also. So that is the benefit of having an EVD. When do you want to put an EVD? Do you want to try putting an EVD before securing the aneurysm or after securing the aneurysm? Can you have can the patient develop hydrocephalus before securing the aneurysm?
Yes, sir. Acute hydrocephalus, it's an early complication because the blood will be accumulating and blocking the foramen.
Yeah.
So it can present even before
Yes.
securing the aneurysm.
Yes. So acute hydrocephalus can be there in patients with acute SH. Soon after developing an SH, they can develop a severe hydrocephalus. So you can put an EVD before securing the aneurysm, and it's found to be safe, and it's not associated with an increased risk of aneurysm re-rupture or anything, and especially if it is accompanied by an early aneurysm repair. Okay, so maybe you can do graded slow drainage initially before securing the aneurysm, and once the aneurysm is secured, maybe yeah, you can, because that transmural pressure gradient, you have to be very careful. Suppose if you're draining the CSF all of a sudden before securing an aneurysm, that itself can cause rupture. So you can put an EVD and it's found to be safe and no associated increased risk of aneurysm rupture, especially if you are combining that with an early aneurysm repair. So that's a guideline. So coming on to other complications like seizures. Next slide, please. Next slide. Next slide. Next slide. Next slide. Next slide. Yeah. So how do you manage seizures? Previous slide.
Seizures can present in about 5 to 10% of patients.
Yeah.
And if the patient is presenting with seizure, we can start anti seizure medication like levetiracetam, 1 gram followed by 500 mg Q12 hourly, and it should be continued to up to 7 days post procedure, and there is no benefit for any prophylactic anti seizure medication. And if the grade of SH is poor, and if there is acute hydrocephalus and cortical ischemia, we can give a trial of anti-seizure medication, and there is no role in prolonging the anti-seizure medication beyond 7 days.
Yes. And which drug do you want to give?
Levetiracetam.
Okay. So levetiracetam, when compared with phenytoin, had a lower incidence of your functional outcomes and cognitive dysfunction. That's why you prefer levetiracetam when compared to phenytoin. Okay. So that's how you manage seizures. So which are the other medical complications that you can have in these kind of patients?
Coming to the cardiac system, the most common will be arrhythmias, then followed by STT changes. There will be ST elevation or depression, and T-wave invasion, and QT prolongation, and then central fever will be there. Then, if the EVD is in situ, the possibility of ventriculitis will be there. Then neurogenic pulmonary edema.
Yes. Okay. So predominantly you can have cardiac and pulmonary complications. Yeah, pulmonary and endocrine, usually electrolyte disturbances. So these are the medical complications that you expect, especially cardiac complications, because they can have a neurogenic stunned myocardium because of the sudden sympathetic surge. They can have severe LV dysfunction. So you have to be very careful in managing such patients, and you can even miss an acute SAH because there's something called sentinel headache. Have you heard of this term, sentinel headache?
Yes, sir. Approximately 20 to 40% of patients will be having a premonitory headache even before the presentation. Usually, the similar type of picture, and it will be resolved by itself, which is a warning sign.
Yeah. So you can miss an SAH at that time. If you image them, the SAH can be very small and can be missed. And the patient may present to you with acute LV dysfunction, pulmonary edema. When you do an ECG, you may see subendocardial ischemia, the inversions. Drop can be elevated. In those cases, if you are giving antiplatelets and anticoagulants, your SAH is going to worsen. So many times your cardiac presentation can be secondary. So you have to clearly ask about a sentinel headache as a symptom, okay, in such kind of patients. So what are the pulmonary complications?
Nephrogenic pulmonary edema.
Yeah. Neurogenic pulmonary edema.
Okay. Sorry, sir.
Then
neurogenic
pulmonary edema. Then you can have ARDS, even ARDS. Okay.
ARDS.
They can have aspiration. Okay.
Yes.
Because of the poor GCS, impaired airway clearance, and later they are prone for hospital acquired pneumonia, all those things. So ARDS is also a complication. All these are pulmonary complications. Suppose if your patient develops an ARDS, how are you going to manage?
ARDS, we can go with the lung protective ventilation, and with a tidal volume of 4 to 6 ml per kg of the predicted body weight, and a PEEP up to 10 can be given. Already the brain blood-brain barrier is disrupted. So these studies have shown that higher PEEP is not detrimental in patients with ARDS with SH, and also in some trials even proning can was considered. So
yeah, so you can even prone. So everything is aimed at improving the oxygenation, maintaining a normal oxygen, normoxemia, because even hypoxia itself can be detrimental for the brain. Okay, you are doing everything to protect your brain from having secondary brain injury. So when you have an ARDS patient in a case of secondary, in a case of acute SH, you have to somehow maintain normoxemia and thereby prevent further worsening of cerebral dysfunction or secondary cerebral injury. So even proning is also advised, and remaining everything is almost the same. Okay, so that's how you manage an ARDS. There are certain studies or review articles about managing an ARDS patient with a high ICP or ARDS in TBI. So you can go back and read. So there are other medical complications also, like hyponatremia or hypomagnesemia and hyper or hypoglycemia. Even all these are detrimental to the brain. So you have to aggressively manage all these. Okay. So these are the important medical complications, non-neurological complications that you can have in managing an SAH patient. So next slide, please. Next slide. Yeah, so this is basically the conclusion. Mortality is obviously high for an acute SAH patient. Early occlusion, preventing vasospasm, and controlling the systemic complications are cornerstone in managing patients with SAH. And obviously, it's all physiology. You have to focus on the physiology, and everything, whatever you are doing to manage such patients is aimed at preventing rebleed and preventing secondary brain injury, so that functional outcomes are also better. So these things you have to focus while managing such cases. Okay, so that's about the case. Thank you. Is there anything that you want to discuss?
no, sir.
Okay, so that's about the case. Thank you.
Thank you, sir.
Thank you, sir.
Thank you.
Thank you, Dr. Prem and Dr. Jyoti, for having a wonderful session today. And we are very happy to have you both for Impact PG, our 10th edition. And we'll meet you in next session. Thank you for everyone. And we touched almost 75 plus students in Zoom, and almost 30 plus students in our YouTube. So it's almost 100 plus students is watching. Thank you for a wonderful session, madam. And thank you, sir. Thank you once again.
Thank you.